Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arora, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to Part 411 of our Pharmacotherapy series, which majors in lower gastrointestinal disorders. This clinical case involves patient TAC from Part 410 of this pharmacotherapy series. TAC is responding well to methylprednisolone. She is afebrile. Her abdominal pain is reduced to a score of 4 on a 1 to 10 scale, and her diarrhea is decreasing. So my first question to you reads: when is the oral route of corticosteroid administration indicated in ulcerative colitis? What are the most appropriate dosages? Oral corticosteroids are effective for the initial treatment of mild to moderate acute ulcerative colitis. In addition, they should be substituted for parenteral corticosteroids once a satisfactory initial response of more severe exacerbations has been achieved. Prednisone of 40 mg per day was significantly more efficacious than 20 mg per day in controlling ambulatory patients with moderately severe acute ulcerative colitis, but prednisone doses of 60 mg per day had no additional therapeutic value, while causing more adverse effects. In addition, a single 40 mg morning dose of prednisone was as effective as and more convenient than an equivalent divided dose, that is 10 mg 4 times a day. Therefore, the initial dose of corticosteroid for a patient with moderately severe acute ulcerative colitis is 40 mg of prednisone or its equivalent administered once daily in the morning. Although corticosteroids are effective for inducing remission in many cases of inflammatory bowel disease, up to 50% of patients may not respond, that is steroid resistant, or will be steroid dependent at 1 year. Additionally, rates of mucosal healing with these drugs are less than those with other modalities. This, combined with the significant adverse effects of corticosteroids, e.g., hyperglycemia, osteoporosis, argue against their long-term use in inflammatory bowel disease, as reflected in current practice guidelines. The next question reads: what if TAC's ulcerative colitis was limited to the distal colon or rectum? Would topical corticosteroids be indicated? When should other topical agents be considered for TAC? Topically administered 5-aminosalicylic acid and corticosteroids, in the form of suppositories, foams, and retention enemas, are effective in the management of acute, mild to moderate ulcerative colitis that is limited to the distal colon and rectum. The desired outcome for medications administered via this topical route is to provide a higher concentration of drug to the diseased mucosal area, exerting a local anti-inflammatory effect, while minimizing systemic side effects. Unfortunately, variable but significant systemic absorption, that is up to 90%, and adrenal suppression occur from the topical administration of corticosteroid to the rectum and distal colon. Therefore, the beneficial effects produced by topical use of these agents may accrue from both systemic and local effects. The relatively low incidence of corticosteroid side effects associated with topical administration may be related to both the low doses and the infrequent administration, that is daily to twice daily, needed to control mild acute ulcerative colitis. 5-aminosalicylic acid suppositories and enemas are preferred over topical corticosteroids for the treatment of distal ulcerative colitis and proctitis because they produce higher remission rates in proctitis and effectively maintain remission of distal ulcerative colitis. For distal ulcerative colitis, therapy is initiated with a nightly enema, 4 grams of mesalamine, and the response should be evaluated in 3 to 4 weeks. For mild acute proctitis, administering 1 suppository of 5-aminosalicylic acid twice daily for 3 to 6 weeks is generally sufficient to induce disease remission. Improvement should be seen in 2 to 3 weeks, and therapy should be maintained until complete remission is achieved. If remission is attained, therapy can then be tapered to 1 suppository or enema, 2 to 3 times weekly. Therapy with oral plus topical mesalamine showed greater efficacy than either alone in achieving remission of distal ulcerative colitis or proctitis. My next question to you reads: what particular corticosteroid adverse effects should the clinician monitor in TAC? Corticosteroid side effects and precautions for use often limit the therapeutic effectiveness of these agents and should never be overlooked. Certain glucocorticoid adverse effects are of particular importance in patients with inflammatory bowel disease in that they may mimic, mask, or intensify symptoms and complications of this disease. For example, the symptoms of peritonitis, one of the major complications of intestinal perforation, may be masked by corticosteroids. Other deleterious effects of corticosteroids include hyperglycemia, avascular necrosis, cataract formation, and central nervous system effects, including mood disorders, insomnia, psychoses, and euphoria. Patients with inflammatory bowel disease are at risk for decreased bone mineral density, which is exacerbated by prolonged use of corticosteroids. This is an often overlooked side effect of these drugs. One study suggested that even budesonide, with its low overall bioavailability, causes this adverse effect. Thus, calcium, vitamin D supplements, and possibly bisphosphonates are recommended to minimize metabolic demineralization in all inflammatory bowel disease patients taking corticosteroids for longer than 3 months. Given the patient's family history, that is a mother with osteoporosis, and her high risk of bone loss, alendronate 35 mg weekly with 1,500 mg daily of calcium and 800 international units of vitamin D intake should be initiated. TAC is still responding well to oral prednisone. However, Her blood glucose concentrations have ranged from 226 to 445 mg per deciliter. The normal range is 70 to 110 mg per deciliter. Her physician would like to try another modality for active treatment. So my question to you is, what other drugs could be used for remission induction? Previously, sulfasalazine was considered the drug of choice in ulcerative colitis exacerbation because of its demonstrated efficacy and reduced toxicity when compared with corticosteroids. However, controlled trials have shown that corticosteroids may act more promptly than sulfasalazine alone for severe acute ulcerative colitis. Sulfasalazine use has declined significantly since the availability of better-tolerated 5-aminosalicylic acid formulations. Additionally, as in the case of TAC, patients with a sulfur allergy should avoid sulfasalazine. Clinical improvement or remission of mild to moderate ulcerative colitis can be attained in 40% to 74% of patients treated with oral 5-aminosalicylic acid in doses ranging from 1.5 to 4.8 grams per day, with further improved response at dosages greater than 2 grams per day. In summary, oral 5-aminosalicylic acid compounds are considered first-line therapy for mild to moderate exacerbations of ulcerative colitis, with systemic corticosteroids reserved for more severe active ulcerative colitis or refractory disease. Because TAC has improved symptomatically and is suffering significant adverse effects from corticosteroid treatment, switching to oral mesalamine is a reasonable option at this time. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 412.